sustained pressure of more normal is 5 to 7 millimeter mercury. Intra-abdominal hypertension is pressure is more than 5 millimeter mercury, more than that, without organ dysfunction. So in intra-abdominal hypertension, it can be classified into 4, where the pressure is ranging from 12 to 15, 15 to 20, 20 to 35, and more than 5. So in the abdominal compartment syndromes, there's a new onset of organ dysfunction, plus with the intra-abdominal pressure more than 20 millimeter mercury. So how do we measure it? We can measure indirect or direct measurements. Direct measurement that we use in the laparoscopic surgery. So there's a transducer in the laparoscopic instrument. While the gold standard that we're using is a indirect measurement. We're using a bladder transducer. So the risk factor for intra-abdominal hypertension or intra-abdominal compartment syndrome is can be further classified into abdominal wall compliance, where patient have burns or surgery, patient have this intra-luminal pressure, gastroparesis, ileus, valvulus, pseudo obstructions, where patient have intra-abdominal pressure increase, where there's ascites, pancreatitis, any tumor or masses, and also the second risk from the outside, where patient have metabolic acidosis, or coagulopathy or trauma, or massive transfusion. So where there's fluid goes inside the peritoneal third space, where in this case is a peritoneal, increase the pressure, causing abdominal compartment syndrome. So how do we manage it? Based on these risk factor that we can classify into intraluminal, abdominal, and also compliance of the wall. So we can manage based on these risk factors. So there's multiple steps that can be implemented, such as the gastrointestinal tube insertion to decompress, rectal tube to decompress, right? Insert the CVD to decompress the bladder, where you can do minimal the feeding in, and also starting the prokinetic in this patient to increase the motility, to evacuate insert the edema, to evacuate the feces, and also lastly is to colonic decompression, where we can do also the ultrasound at first beginning, and subsequently CT abdomen to identify the lesion, and then lastly we need to open to evacuate the tumor if there's present of the tumor or any masses, or is there any ascites, we can do a pigtail incision to evacuate the ascites. For the abdominal wall compliance, you can ask the anesthetist to give a sedation, enough sedation and muscle relaxants to relax the abdominal walls, and also to increase the ventilation, okay, to improve the ventilation. So lastly, if it's all failed with new onset of organ dysfunction, lastly is the laparostomy, where we use a temporary abdominal wall, abdominal closure, to give space for the pressure to reduce and subsequently improve the organ dysfunction, such as the kidneys, the cardio, and also heart, and also the lungs. So that's all for my 2 minutes presentation.